Hello, good evening, friends. And today we'll be discussing about a topic of malrotation of gut. So before starting, I would like to thank Chandana Shri Ma'am for sharing the wonderful notes with us, which are very helpful for quick revision. And the link for the notes is given in the description below. You can download it from there. So without further delay, let's get started. So definition of malrotation of gut. So it's a group of abnormality due to abnormal rotation and fixation of the intestine. And the embryological basics, that is, initially there is the abdominal content, that is the intestine, come out of the umbilicus and start rotation in the counterclockwise direction. So the first cranial limb, that is the distal duodenum and jejunum, that is the and proximal ileum, the cranial limb, that is rotating along with the caudal limb in the counterclockwise direction. The caudal limb contains the distal ileum and colon, and these rotate along the superior mesenteric artery and the vital intestinal duct. Then this happens at around 5 weeks, and then in the 9th week there is further 180-degree rotation, causing the caudal limb coming to the right side and transverse colon in front of the duodenum. Then there is further reduction, causing descent of the cecum and regression of the vitalointestinal duct, and the intestine return to the abdominal cavity. This happens at around 11 weeks, that is stage 2, that is the reduction. And in stage 3, there occurs fixation of cecum and DJ flexure and sigmoid colon to the posterior abdominal wall. So this is all about the basics, embryological basics of rotation of the gut. This happens normally. And the endoderm of the yolk sac forms the primitive gut, and due to folding of the embryo in the craniocaudal direction, this rotation occurs in starting from the 4th week of gestation up to the 12th week. The endoderm forms the epithelial lining of intestine. The splanchnic mesoderm forms the other layer and the mesentery, and the neuroectoderm forms the nerves. Then the physiological herniation of midgut through the umbilicus in the 5th week, as you have seen in the diagram. Then endodermal proliferation and temporary occlusion of lumen in the 5th week. Growth and expansion of mesoderm, apoptosis of the ectoderm causing recanalization in the 7th week. And lastly, the intestine returns to the abdominal cavity after rotation in the 10th to 12th week. So in the stage 1, there is physiological herniation of midgut through the umbilicus, that is in the 4th to 10th week. In the stage 2, there will be reduction from 10th to 12th week. Migration of herniated contents back to the abdomen, small bowel first and followed by cecocolic loop, and cecum initially lies to the left, which rotates 270 degree in the counterclockwise direction, coming to the right position, right side. Then stage 3, there is fixation of the duodenojejunal loop to the left and cecum to the right lower quadrant. Now we see the disorders of this malrotation of gut. So in first, there is non-rotation of the gut. So there will be arrest in stage 1, no rotation of either duodenojejunal limb or a cecocolic limb. Duodenojejunal flexure does not lie to the left of the SMA, and cecum does not lie in the right lower quadrant. So here, if the base of the mesentery is fairly narrow, it can result in volvulus. So like this is the picture in the non-rotation, where the small ball is in the right side and the cecum and the large ball in the left side. Then there is incomplete rotation, where there is arrest in the stage 2. So here there are 3 conditions, that is duodenal obstruction, It is due to the Ladd's band, which is a peritoneal band running from the cecum to the mesentery, causing compression of the third part of duodenum. Here we can see in the diagram the Ladd's band causing compression of the second part of duodenum. Third part of the duodenum. So the other disorder that can happen is a midgut volvulus due to narrow mesentery at the base, causing twist in the clockwise direction. And lastly, the internal hernia, if the duodenojejunal loop does not rotate, that is the cranial limb, but the cecocolic loop rotates and gets fixed, then most of the small bowel is trapped in the mesentery of the large bowel. So the cranial limb does not rotate, the caudal limb rotates, causing fixation of the small bowel, the duodenojejunal loop within the mesentery of the large bowel, causing right mesocolic hernia, the right mesocolic hernia or right paraduodenal hernia. Lastly, incomplete fixation, that is arrest in stage 3, if the hernial pouches form when the mesentery of the right and left colon and duodenum do not become fixed retroperitoneally. So after going inside, the intestines going inside in the stage 3, if these does not fix, they can result in left mesocolic hernia, that is migration of left intestine, small intestine in the left upper quadrant due to non-fixation of the descending mesocolon between the IMA and the posterior parietal attachment. So this result in left paraduodenal hernia where there is non-fixation of the descending mesocolon between the IMA and the posterior parietal attachments. So this result in left mesocolic or left paraduodenal hernia. So the hernia gaps between the inferior mesenteric vein here, the left mesocolic or paraduodenal hernia, the gap between the inferior mesenteric vein. Now the clinical presentation, it can present as volvulus, both could be acute chronic, could be acute duodenal obstruction or internal herniation. So acute midgut volvulus occurs generally in the first year of life, causing acute onset bilious vomiting, and X-ray will show dilated bowel loop with paucity of dilated distal gas. In chronic volvulus, there will be intermittent partial twisting causing lymphatic and venous obstruction, causing recurrent abdominal pain, malabsorption, altered bowel habits, and gastrointestinal reflux. In acute duodenal obstruction, there could be Ladd's band, and presentation is in infancy or preschool children, causing signs of obstruction. Internal herniation could be right or left paraduodenal hernia, causing intermittent abdominal pain, hematochezia, dilated abdominal veins, etc. Investigation we go for, that is CBC, will show sepsis, decreased HP in case of GI bleed. ABG may show acidosis, metabolic acidosis, serum electrolyte may show hyperkalemia, coagulation profile may show abnormal DIC, disseminated intravascular coagulation due to deranged coagulation profile. Then chest X-ray showing abdominal X-ray, erect abdomen X-ray, showing distended abdomen and proximal duodenum, UGI contrast series, which can be done in stable patient. Normally the duodenojejunal fracture is left in the left of the midline above the pylorus, and in typical malrotation there could be duodenojejunal fracture in the right of midline, or it could even be absent. A typical duodenojejunal fracture in the midline or left of the midline below the pylorus. So these two conditions are malrotation. There will be abrupt tapering of the contrast, which is suggestive of volvulus. Then lower GI series, which is rarely indicated in case for cecal localization. USG abdomen is mostly sensitive 100% in the expert hands. There what we can see is inversion of SMA and SMV, fixed midline bowel loops, and duodenal dilatation with distal tapering, CT coiling of SMV around SMA with volvulus. Management: stabilize the patient initially with NG tube, IV securing IV line, and correcting the fluid and electrolyte deficit, starting antibiotic that is broad spectrum. And in case of acute, we can consider immediate surgery. In stable patient, we can further evaluate and then plan for surgery. Surgery is done for these malrotation cases is the LADS procedure, where we reduce the volvulus, the torsion by counterclockwise rotation, place warm towel and observe. If there is a viability, we can allow. If there is impaired viability, we have to resect the gangrenous segments. Divide the LADS band, which extends from the third part of duodenum from the ascending colon to the right upper quadrant in the posterior aspect. Sorry for the disturbance. So we were at dividing the LADS band, which extends from the third part of duodenum to the ascending colon, from the ascending colon to the right upper quadrant posteriorly. And then we have to widen the mesenteric base by mobilizing the cecum so that there is no further volvulus formation. Incidental appendectomy if needed. Bowel loops are replaced in the abdomen, that is the small bowel on the right side, cecum and large bowel on the left side. Then we close the abdomen after thorough wash. And lastly, we can also do the laparoscopic LAD procedure. So this was all about malrotation of gut. Hope it has been understood, and thank you for watching. Please like, share and subscribe, and keep studying, keep growing. Never give up, because great things take time. Thank you. See you in next video.